Senator says, Rudy, thank you for coming in. We have about 7 minutes. Please tell me what you would like us to know. I respond, Senator Padilla, thank you for meeting with me. I also want to thank you for helping launch the bipartisan Senate Mental Health Caucus and for making crisis response and evidence-based mental health care part of its mission. My name is Rudy Ortiz. I'm a BSN prepared registered nurse working in psychiatric care in Southern California, and I am also a psychiatric mental health nurse practitioner student. I am here as a psychiatric nurse advocate for patients, families, and frontline nurses. I want to focus on one narrow gap in crisis care. When a person is severely agitated, emergency medication can prevent serious injury and allow treatment to begin. But when medication is given involuntarily, mainly to control behavior, it can also become a restraint. Federal regulation defined that line, yet our national quality system measures physical restraint and seclusion more clearly than medication used as a restraint. I am here to ask your office to help close that gap without slowing emergency care. Let me tell you about Daniel. Daniel is a de-identified composite of situations psychiatric nurses commonly encounter. The details have been changed to protect privacy. He was a 27-year-old Southern Californian brought to an acute psychiatric setting after several nights without sleep. He was frightened, hearing threatening voices, pacing, and shouting. His fists were clenched. When several staff members gathered in the doorway, he became more alarmed because he believed he was about to be attacked. One nurse asked the extra staff to step back, lowered the stimulation in the room, used Daniel's preferred name, and gave him 2 clear medication choices. She offered water, explained what each option would do, and asked what had helped him in the past. Daniel accepted an oral medication. For a period of time, that avoided a forced injection and gave him some control. Later, his symptoms intensified and he moved toward another patient in a way that created an immediate safety threat. At that point, emergency intramuscular medication was clinically necessary. The team administered it, monitored his breathing and vital signs, reassessed him, and stayed with him. The next day, Daniel participated in a debrief. He explained that being surrounded had made him feel as if he were being assaulted. I share this story because the ethical issue is not simply whether the medication was used. The ethical difference was the process. Was there immediate danger? Were less restrictive options attempted? Was the medication treating the condition rather than serving staff convenience? Was the patient monitored? Did the team learn from the event? Daniel's medication may have prevented injury, but the de-escalation, monitoring, and debriefing protected his dignity and made the next crisis safer. The problem is that many records reduce these events to a line such as patient agitated, I am medication given. That does not tell a hospital, a regulator, or a patient whether the intervention met the ethical and legal standard. CMS already says restraint may be used only for immediate safety after less restrictive interventions are ineffective and or the shortest time necessary. CMS also defines a medication as a restraint when it is used to manage behavior or restrict movement and is not a standard treatment or dose for the patient's condition. Yet the fiscal year 2026 inpatient psychiatric quality measures list hours of physical restraint and seclusion with no parallel measure for medication used as a restraint. SAMHSA's 2005 Crisis Care Guidance recommends collecting data on involuntary interventions so systems can minimize them. My ask is this. Will you lead a bipartisan Senate Mental Health Caucus letter to the Department of Health and Human Services asking CMS and SAMHSA to develop and pilot a national emergency behavioral medication safety and transparency framework for Medicare participating hospitals? The framework should be practical and limited to core safeguards. One definition that distinguishes treatment from restraint, documentation of the immediate safety threat and less restrictive steps attempted, the medication route, dose, monitoring, reassessment, and adverse events, a patient-centered post-event debrief and crisis preference plan, and aggregate privacy-protected data that can reveal practice variation and inequities. It should be piloted through existing electronic health records and quality reporting workflows before any public reporting requirement. Senator would say, Will this create more paperwork or slow nurses down when someone is dangerous? And I respond, it should not. The framework must explicitly preserve treatment first when danger is immediate. Nurses would intervene, stabilize, and then complete a brief standardized record during or immediately after the event. Much of the information is already documented in different places. A pilot can determine the smallest reliable data set and remove duplicate charting. The goal is safer, rapid care, not slower care. Senator Stafford would say, hospitals already have restraint regulations. Why is federal action needed? I would respond, the federal right exists, but the measurement is incomplete. Hospitals report physical restraint and seclusion through established psychiatric quality measures. Medication use as restraint is recognized in federal regulation, yet it is not represented by comparable national quality measure. Without a common definition in core data fields, hospitals cannot benchmark practice, identify outliers, or know whether improvement efforts are working. APNA has specifically called for common definitions, consistent data requirements, and standardized electronic health records. Senator Stafford would say, what would you need from our office next? And I say, first, I would appreciate the name of the health policy staff member who should receive follow-up materials. Within 2 weeks, I can send a draft, bipartisan letter, and a one-page proposed core data set. I would also welcome a brief caucus roundtable with psychiatric nurses, people with lived experience, emergency psychiatry, hospital, quality leaders, CMS, and SAMHSA, so the framework is designed with both patient rights and staff safety in mind. Thank you for your time and for your work on mental health crisis care. Patients should not have to choose between safety and dignity, and nurses should not have to choose between acting quickly and practicing ethically. A common national framework can protect both. May I follow up with your health policy staff within 2 weeks? Senator Stafford would respond, yes. Please send the draft and proposed data elements to our health policy team. We will review whether the caucus can convene the appropriate partners. I would say, thank you, Senator. I appreciate the opportunity and will send the materials by the agreed date.